you mentioned Leqembi, and I'd love to dig into that a little bit because there was a
Mhm.
session at the conference where the University of Washington's Memory and Brain Wellness Center study was shared by Dr. Michael Rosenblum on Leqembi, and it highlighted that key trade-off of academic clinics offering more advanced infrastructure versus private clinics initiating treatment significantly faster and having equal safety. So given that the study's main takeaway is that sooner is better, how do you think this is going to shape patient choices and influence the future of care delivery?
It's so interesting when we compare our academic settings that have, to your point, lots of infrastructure, wonderful researchers, heavy NIH grants, but they also have different incentives for what they need to be doing, right? To further the institution's mission. That includes research, that includes grant writing, that includes publications. Those are all things that take up time. And it's just a different set of incentives. When you go to the other institutions, the non-academic, whether those be, private or not-for-profit, right? There's a lot of not-for-profit hospitals in the United States. Their incentive is around making sure that they can financially stay afloat. And what's interesting is today in this country, neurology is a losing specialty. Neurologists don't do large, expensive um, interventions like cardiology or orthopedics, and as such, neurology is often a place where hospitals are watching close to see what's going on. So for those systems where those financial incentives are really important, volume and throughput matter. And they're running a business. I mean, healthcare is a business.
Mhm.
So you do see a lot quicker uptake. You see faster decision making. The cycle for governance and for decisions to be made are much quicker. Um, and then you see those systems m- adapting workflows very fast. Unfortunately, it's not the norm for people in the United States to be diagnosed at all with Alzheimer's disease. And it's certainly not the norm for them to be diagnosed early. And so it takes a full mindset, culture shift, workflow change. And workflow change is hard. And it's really hard in an academic institution where the disciplines are set up, sometimes independently, or like I said, they just have different incentives. So you asked about the question of patient choice. Um, I'm not sure that your average patient is going to know the difference between those two things. I do think your, affluent, educated population that's out on Google that wants to do these things, they can find the information. And I think those folks will move someplace where they have the opportunity to get the therapy if they want it. I have had several uh, friends call and say, we went to XYZ academic institution. We thought it was the best. They're telling us we have this really long wait. Where should we go? And I was like, well, try this institution. And sure enough, they were able to get that infusion earlier and they know that early matters. So I do think for a subset of our population, a very, very small subset of the population in the US, people will potentially chase that. But I think for the most part, you're just gonna have kind of variable access because of different uptake, rates.
Well, it ties back, like you said, to that phrase again, equity and access, right? I think the more we can streamline things and make policies similar across institutions across the country, hopefully we can improve that access so that, people of privilege and who have the ability to be able to move or to be able to travel for care, that's not just isolated to that group, that population, that everyone can have access to that.
I don't think there's a disease state that I've ever worked in where kind of health seekers aren't the first users, right? I mean, and the
Yeah.
first patients. It just is normal. Our goal as a field should be for that to be as short a time period as possible before things even out. It's really important when you look at the impact. So today, the standard of care in the United States of America for Alzheimer's disease is an unpaid family caregiver.
Mhm.
We're one of the wealthiest nations in the world. And our standard of care for this disease that impacts millions of people in our country is an unpaid family caregiver. And so you can imagine this has generational impact as well. If people are having to leave the workforce to be a caregiver, or if they're, having to buy down assets in order to be able to get to Medicaid. And so we're going to see a really long tail of a lack of health equity if we're not careful. And we do know that people with lower social determinants of health are at higher risk. We know that communities of color are at higher risk. And so it's one of the reasons I went and got this public health degree, because I just think we need to be thinking about brain health like we do other public health topics. And we need to make sure that as fast as possible, we move out of this, affluent, privileged setting of the people who get the therapies to anyone who wants the therapy or would be a candidate for therapy being able to have access.
Yeah, outstanding. And so true. I mean, the other piece on that is that access point and the caregivers a lot of times right now are sandwich generation, right? They've
Yeah.
got young adult children who may be finishing high school, heading into early college, and then they're starting to care for an aging parent. And, the data on the impact and the increased risk for a person who is themselves a caregiver. I mean, I think that's the other thing, lifestyle factors being so important. And when you're in a caregiver role, especially if you're also still raising kiddos and still trying to work, is you're not sleeping as well and you're not exercising as much as you should be, and you're having more social isolation because you're spending more time caring as opposed to connecting with outside individuals, and each of those cascades together, which then increases the next generational risk. So yeah, I think it's so
Absolutely. We know stress, lack of sleep, but here's another scenario for you. What about the 20-year-old kid who's caring for his grandmother
yeah,
because she raised him?
right,
And now he's potentially having to alter his life course to care for the woman that cared for him. And so I just think these are things that are fixable.
yeah,
And we as a society should say, let's get them fixed. These aren't things that we necessarily have to wait for science to fix. These are, I'm not going to say healthcare system transformation is easy. I'm telling you, it is not for the faint of heart, but it is an engineering solvable problem.
yeah.
And it's simpler with the exception of the way our billing codes work in this country, but it's easier than coming up with a new drug. So let's
Absolutely.
fix it, right? Let's fix it. And then, of course, I'd be remiss if I didn't say the other benefit of early detection is people can be offered a clinical trial as part of their care plan. And today, we do not have enough clinical trial participants to adjudicate the full number of clinical trials that we have in our pipeline. And so that's the other reason that early detection is so important, and that we're making sure that anyone in any community has the same access to clinical trials as well.